A very good morning to one and all. On behalf of the Indian Academy of Pediatrics, Tamil Nadu State Chapter, and the organizing committee of Sangamam Pedicon 2.0, we welcome you all on this grand Sunday morning for the BRS Award. Professor B.R. Santana Krishnan Award is one of the major awards which is being awarded every year to the budding pediatrician in the field of gender pediatrics, including neonatology. Professor B.R. Santana Krishnan was popularly known as BRS. He was a walking encyclopedia in pediatrics. He hailed from Kovilpatti and served in all 3 tiers of Tamil Nadu Medical Service. After returning from the US with an AB in pediatrics, he served as the Assistant Director of Medical Education and migrated to the ICH as additional professor and became the director of the institute, which assignment he completed creditably until his superannuation. He served IAP Tamil Nadu State Chapter in various capacities as its editor, treasurer, secretary, and president, and was also the Central IAP EB member for several terms and was conferred FIAP for his services to the children of India. He was an excellent teacher with profound knowledge in pediatric therapeutics. The BRS drug dosage book, being regularly published, stands testimony to his proficiency. Professor B.R. Santana Krishnan Award is awarded to a teaching institute and also a candidate from a non-teaching institute, and unfortunately we did not have award papers competing for the non-teaching category. So this oral presentation will be for 8 minutes and 2 minutes will be allowed for discussion. Questions are only from the judges and it will be answered by the presenter only. So to judge this most renowned award, I welcome Professor Dr. L.R.C., former director of the Institute of Child Health and Hospital for Children and presently head of the department, Savitha Medical College. Dr. Vishwanathan, senior consultant pediatrician and gastroenterologist, Apollo Hospitals, Chennai. Dr. Thirumurugan Seran, director, AG Padmavati Hospitals and honorary secretary of IAP Tamil Nadu State Chapter. The first presenter, Dr. Sasikala, efficacy of VAP bundle in reducing VAP in a tertiary care center. Over to the presenter.
Good morning, respected judges and audience. My study is about efficacy of VAP bundle in reducing the ventilator-associated pneumonia in neonates admitted in a tertiary care SNCU. Introduction. Infant mortality rate is often regarded as a barometer for overall welfare of a community or country. According to Registered Journal of India, IMR declined from 48 to 28 per thousand live births in the last decade, but NMR declined from 30 to 25 only. NMR is a major contributor for IMR. Common causes for neonatal mortality: prematurity, hyaline membrane disease, birth asphyxia, sepsis, including acquired problem like VAP. In previous years, neonatal care, awareness and infrastructure were lagging in many parts of our country, but nowadays it was improved because of National Health Mission all over country, despite NMR is still high in many places. Neonates are in need of ventilator care for extreme preterm, very low birth weight, HMD during surfactant administration, severe birth asphyxia, in sepsis, seizures and congenital pneumonia. Because of prolonged ventilation susceptibility to infection, VAP is common hospital-acquired infection in newborn. It also increased the usage of antibiotics and its resistance, increased cost of treatment and hospital stay. So decreasing the VAP is one of the best way to increase neonatal outcome. VAP is defined as nosocomial infection diagnosed in patients undergoing mechanical ventilation for at least 48 hours on the date of event, with the day of ventilator placement being day 1 and ventilator was in place on the date of event or the day before. Strategies to prevent VAP: routine mouth care, appropriate hand cleansing and wearing gloves when handling secretions, which will minimize bacterial colonization of oropharynx and stomach. Studies regarding VAP bundle are very minimal in essence use in the developing countries where neonatal mortality is still high. Our objective is to compare the VAP rate before and after implementation of VAP bundle in SNCU of tertiary care center to study whether it reduces VAP incidence, mortality, duration of mechanical ventilation, duration of hospital stay and extubation failure. Study design: it was prospective before and after intervention study conducted in SNCU from December 2018 to June 2020. That is pre-intervention group, that is before implementation of VAP bundle, were studied for 7 months. In post-intervention were studied for 12 months. Inclusion criteria: neonates up to 28 days of life and those on mechanical ventilation for more than 48 hours. Excluded those on mechanical ventilation for less than 48 hours, babies with CDH, TEF, congenital pneumonia, MAS, birth weight less than 1 kg. For initial 7 months, all babies were managed according to our routine unit protocol. Protocol used was hand hygiene. All cases were entered by orotracheal tube. Open section method used. Ventilator circuit was changed if solid or condensate. Frequent change in position from right and left lateral. Orogastric tube put in all neonates. Colostrum application was done. Total and differential leukocyte count, CRP, extraches taken at the time of intubation and subsequently whenever needed. Blood culture and VT tube culture also done whenever needed. We suspect VAP based on the finding of new onset of abnormal chest X-ray and clinical findings of worsening of gas exchange, increased oxygen requirements or increased ventilator demand, new onset purulent tracheal secretion, change in character of sputum, temperature instability, or baby develops apnea or tachypnea. For next 12 months, VAP bundle components were strictly implemented, followed and monitored continuously. VAP bundle components are hand hygiene, head of bed elevation 30 to 45 degree, oral care, readiness to extubation assessment, sterile suctioning and handling of respiratory equipments, evaluation of ventilator circuit and changing the circuit when soiled or malfunctioning, periodical draining of ventilator circuit condensate. These were explained in detail to all residents and staff nurses of our SNCU, displayed through posters in our SNCU. It was implemented and strictly instructed to follow for the next 12 months. Clinical profile, indications for intubation, total mechanical ventilated babies, total MV days, total VAP episodes, and complaints to VAP bundle components were calculated. We calculated VAP rate, VAP incidence, extubation failure rate, duration of hospital stay, mortality were calculated for both pre and post intervention group. VAP rate per 1000 ventilator days equal to number of VAPs by number of ventilator days into 1000. Parental consent and ethical committee clearance obtained. Statistical analysis was done. Results: total number of babies ventilated during the study 190, eligible is 195, excluded 25. In before intervention group 90 babies were included, in the after intervention group 80 babies were included. Results: risk factors for intubation in both pre and post intervention group is hyaline membrane disease, sepsis followed by birth asphyxia. Blood culture and ET culture results: positivity in 38% positive in pre-intervention group and 15% in post-intervention group. ET culture positivity 25% in pre-intervention, 7.5% in post-intervention group. VAP rates were compared. In after-intervention group, it was significantly decreased from 25 to 15. VAP per 1000 MV days decreased from 41.7% to 21.3%, which was statistically significant. We compared secondary outcomes. VAP incidence significantly reduced from 41% to 18% in post-intervention group. Extubation failure decreased from 30% to 11% in post-intervention group. Mortality decreased from 38% to 10% in post-intervention group, which was statistically significant. Complaints of all VAP bundle components were significantly increased in post-intervention group except readiness to extubation assessment. Discussion. Because death due to HMD in preterm is drastically reduced because of availability and usage of surfactant all over country, but still premature remains the leading cause of death in many SNCUs, mainly due to secondary sepsis and VAP. Neonates more prone to hospital-acquired infections because of low immunity and high chance of contamination. Prolonged mechanical ventilation newborn is a common cause for VAP reported in many studies. Baby recovers from the primary illness but succumbs to death because of secondary cause of VAP. Hand hygiene is the single most important factor to control hospital-acquired infection, but very difficult strategy to maintain properly and sincerely. Many gram-negative organisms carried on the hands of caregivers will lead to VAP. Head end of bed elevation, very simple, easy to use, important factor to prevent aspiration. Oral hygiene, neonates are at risk of contaminated oral secretions because ET tubes used to ventilate them are uncuffed. Oral colostrum application and oral hygiene will improve local immunity. Ready to extubation assessment should be done daily to decrease the duration of mechanical ventilation and its consequences. Sterile suctioning is very important, by which we can prevent the secondary infection of lung effectively. Evaluation of ventilator circuit and changing when soiled is very much essential, where large numbers of babies were ventilated in SNCU in developing countries like India. Periodical draining of ventilator circuit condensate should be done regularly to prevent the secondary infection. The strategies which will improve the care individually when applying many together will result in very good improvement in the desired outcome. So, we have significant reduction in VAP from 41% to 21%. There was significant reduction in VAP incidence from 41% to 18.75% in after intervention group. Mortality rate also decreased significantly. Extubation failure decreased significantly from 30% to 11%. Needed for intubation is reduced significantly. But the duration of hospital stay and MV days were not statistically improved in our study because many Extreme preterm and low birth weight babies are admitted in the post-intervention group. They need more time to meet the discharge criteria. Complaints of all WAP bundle components except readiness to win assessment were significantly improved in the post-intervention group because the confidence and assessment to wean off from ventilator will vary among residents and staff nurses. So it was not significantly improved in our study. In many circumstances, invasive ventilation is unavoidable. So, plan to extubate to NIV should be the important checklist to be followed in every SNCU regularly because non-invasive ventilation has lesser complications of WAP and ET block and it is baby friendly too. Strength of our study, protocol-based checklist and ensuring better compliance of WAP bundle. Along with WAP rate and incidence, we studied many factors. Limitation of our study, subgroup analysis with respect to gestational age or birth weight not done. It's single center study. Conclusion, WAP bundle care significantly decreased the incidence and rate of WAP. Neonatal mortality and extubation failure significantly reduced. It's very easy to follow. With minimal training and by employing checklist, complaints can be achieved in any SNCU which will improve the neonatal outcome. It's very cost effective method in developing countries like India to decrease NMR and IMR. Thank you. Thank you for this opportunity.
Can I ask? It's a very good presentation and a good study. And regarding the hand hygiene, you said it's very difficult to follow, or why you think it is so difficult?
Regular. All depends on their because before touching the every baby they should maintain hand hygiene, ma'am. They should have an instance that they should sanitize the hands before handling every baby, ma'am.
So how do you think we can overcome this?
It should be implemented as a policy, ma'am. We should check.
Okay.
A brief question from me. Well done, very good presentation.
Thank you.
One thing I want to ask you is, the carers doing the hand wash, carers, parents doing the hand wash, who is supervising that?
Sir?
Who will be supervising the parents or the carers hand washing technique? I just want to know.
Okay, sir.
The hand wash has been taught to parents, the carers. Who will supervise their hand washing technique?
Sir, we are having in-charge staff nurse. We have hand washing area at the entrance of our SNCU units.
Was it done? Was it being supervised meticulously for
yes,
all?
Yes, sir. Yes, sir. Because we are having many preterm babies, so it was strictly followed in our units, sir.
Okay, couple of questions. One again comes back to the hand washing. How did you do an audit trail during the first and the second phase of your trial to say that you really had a hand washing done? Or how did you confirm it? I mean, you see, normally in any NSU we say they have to wash hands. How did you monitor the behavioral change?
Sir, we have put a WAP bundle worksheets, sir.
No, that I agree. See,
okay.
you put it, but how you have they made sure that it worked.
Sir, actually, we are having in-charge staff nurse. She will be monitoring everything, sir.
But was that included in part of your study protocol?
Sir, it was explained to all residents and staff nurses.
Okay, fine.
Sir.
The second question is, see, in a 6 or 7 month period, you had 600 mechanical ventilation days, whereas in a 12-month period, you had only 700. So, is it possible that because you were less busy in the second half, the outcome was better and not because of your WAP bundle?
Sir, in post-intervention group, we had the decreased incidence and rate of...
No, that I agree. I'm not contesting your finding. I'm just asking,
sir.
Is it just that your unit became less busy?
Yes.
And then could that have had an impact on
No, no, sir. We had more preterm babies in post-intervention group. Because of this implementation of WAP, we have decreased the incidence and WAP. Thank you, sir.
Thank you, judges, and thank you, Dr. Sasikula. The next presenter is Dr. Karthipan. Cardiac manifestations in MISC and its follow-up, a prospective observational study.
Good morning to one and all present here. I am happy to start my presentation on cardiac manifestation in MISC and its follow-up, a prospective observation study. So, multi-system inflammatory syndrome in children was one of the most intriguing manifestations in COVID-19, which threw a huge puzzle to the healthcare population. Prominent cardiovascular manifestation, including myocardial dysfunction and coronary artery involvement, have been identified in children with MISC. This study focuses on the various cardiac manifestations and its association with inflammatory markers, treatment response, and resolution of the manifestations on follow-up. So the aim of our study is to study the cardiovascular manifestation MISI, the treatment response, and the course of disease on follow-up. The objectives were to study the incidence of cardiac manifestation MISI, children affected with MISI, to study the association between cardiac manifestation and inflammatory markers along with treatment response, to study the course of cardiovascular manifestation on periodic follow-up. This was a prospective observation study which was carried out for a period of 1.5 years from August 2020 to February 2022 at a tertiary care center. Children below 12 years of age diagnosed to have MIS-C based on the WHO criteria were included in our study, and children with known history of congenital heart disease, cardiomyopathies, rheumatic heart disease, immunodeficiency disorders, leukemia, thalassemia, and other significant ailments were excluded from the study. The methodology: first, informed written consent were obtained from all patients who fitted into our inclusion criteria. The baseline investigations such as CBC, ESR, CRP, serum ferritin, serum albumin, ECG, echocardiogram, and cardiac enzymes are obtained. In echocardiogram, left ventricular internal diameter during systole and diastole, and coronary artery diameter based on Boston is its score were monitored. Treatment response was monitored by looking at the duration of inotrope support required, requirement of steroids, that is IV methylprednisolone, intravenous immunoglobulins, anticoagulants, and the total duration of hospital stay. All the cardiac cases were followed up with serial echocardiogram to look for resolution. That is, a monthly follow-up was carried out until the resolution of the cardiac manifestation. Then once third monthly follow-up was done for the other patients. Data analysis was done using SPSS version 25 software. Continuous variables were presented as mean and standard deviation, and categorical variables as frequency distribution percentage. Association among categorical variables were tested using chi-square test. A p-value less than 0.05 is taken to denote a significant relationship. So coming to the results, a total of 70 participants who fitted into the inclusion criteria was taken into the study. The median age of the population was 5.5 years, with 58.4% boys and 41.46% girls. The average duration of hospital stay was 9.85 days. 7.2% of patients or children were found to be positive for SARS-CoV-19 PCR test, while 92.8% of the children were found to be positive for COVID antibody, that is post-COVID sequelae. Coming to the interventions, a total of 18.6% of the total participants required inotrope support, 91.4% required methylprednisolone support, 57.1% required intravenous immunoglobulin, 34.3% required aspirin, and 12.9% required anticoagulants. Total of 31.4% of the total participants had features such as hypotension or shock, 17.1% had features such as myocarditis or ventricular dysfunction, and 5.7% individuals had features such as coronary ectasia. On comparing the cardiac manifestation with various lab parameters, it was found that platelet count, serum ferritin, serum albumin, and CRP had no significant relationship with the cardiac manifestation, while ESR, a higher ESR value, was found to have a positive predictive correlation, significant correlation with both myocarditis and coronary ectasia. Coming to the individual cardiac manifestation, myocarditis and ventricular dysfunction, we had 7 patients with mild ventricular dysfunction, 4 children with moderate ventricular dysfunction, and 1 children with severe ventricular dysfunction. IVIG was required in all 12 individuals with cardiac manifestation. Aspirin was required in 83.3% of the individuals, that's 10 children. Anticoagulants was used in 41.6% of the individuals, it's 5 out of 12 individuals. Along with the coronary ectasia, 2 children, that is 50% of the children had moderate ventricular dysfunction, and 50% of the children, that is 2 out of 4, had severe ventricular dysfunction. IVIG and anticoagulants were used in all the 4 individuals with intravenous immunoglobulin. Aspirin was required in 2 individuals. Coronary ectasia requires aspirin therapy, but the 2 children here had thrombocytopenia, so aspirin could not be used in those 2 children with coronary ectasia. Coming on to the therapeutic intervention, we split the therapeutic intervention to those children requiring only intravenous methylprednisolone, only requiring intravenous in IVIG, and a combination of both intravenous methylprednisolone and IVIG. So a total of 30 out of 70 children required only intravenous methylprednisolone. All these children had manifestation of mild MISC. None of the children had myocarditis or coronary ectasia, and none of them required aspirin or anticoagulant in addition. A total of 6 children required IVIG of the total 70, out of which 2 children had myocarditis. 1 children was actually suspected to have a Kawasaki disease, but only after treatment we found out that the children was turning out to be positive for COVID antibody. 1 children received additional aspirin. A total of 34 children, that is 48.5% of the participants had received both intravenous methylprednisolone and intravenous immunoglobulin. 10 children had features of myocarditis and 4 children had features of coronary ectasia. Or these 20 children were treated with add-on aspirin and 9 children were treated with an add-on subcutaneous enoxaparin. So there were 4 children with coronary ectasia who were kept on a serial follow-up. Most common was right coronary artery dilatation. At day 56 of discharge, that is 2 months after discharge, we found that 50% of the children had the resolution of the cardiac manifestation, while at the end of 3 months, all the children had resolution of their cardiac coronary artery dilatation. So myocarditis and ventricular dysfunction was most commonly found in female participants in our study. The children affected with myocarditis had an average duration of fever for 7 days, and a higher ESR was most closely related to left ventricular dysfunction, which was statistically significant. Patients required an iron drop support for an average of 2.1 days. All the children required intravenous immunoglobulin, 83.3% required aspirin, and 41.6% required anticoagulants. The average duration of stay was 12.2 days, and 41.6% of the children had resolution of the cardiac manifestation on the day of discharge, with everyone showing resolution of the cardiac manifestation within 1 month after discharge. Coronary ectasia was most commonly found in female participants. The children had an average duration of fever for 3 to 7 days. Higher ESR was again statistically associated with coronary ectasia. Every children required IVIG and anticoagulant, with 50% requiring aspirin. The average duration of hospital stay was 11.7 days. 50% of the children had resolution within 2 months, and all the children had resolution of ectasia within 84 months of admission. This is a review of literature comparing our study with all other major studies. The major finding is that we had a lesser incidence of myocarditis, that is left ventricular dysfunction, probably due to an initial intervention with intravenous methylprednisolone. And again, we had many children requiring only intravenous methylprednisolone, a 42.9%. So the knowledge of Missy is developing. The most cardiac manifestation as is ventricular dysfunction, followed by coronary ectasia. ESR is a major marker for early identification of children with risk for cardiac manifestation. Most of the children required a combination of intravenous immunoglobulin and methylprednisolone. Early detection and appropriate treatment with a multidisciplinary team in an intensive care unit and aggressive chemotherapy will help in avoiding complications. Thank you.
Okay. What was the study? What was the protocol for the treatment of these patients? Did you have a protocol? I mean, your whole results is all about how many percentage was needed for any. So how did you? What was the clear protocol for?
For mild Missy, we had intravenous methylprednisolone 2 to 3 mg per kg as a standalone treatment. For children with Missy and cardiac manifestation, intravenous methylprednisolone 2 to 3 mg per kg plus intravenous immunoglobulin 1 gram per kg per day for 2 days. With children with Missy and Kawasaki phenotype, it was intravenous methylprednisolone 2 to 3 mg per kg with intravenous immunoglobulin 2 gram per kg for 1 day plus aspirin 3 to 5 mg per kg. For those with refractory Missy, we used intravenous methylprednisolone at 10 mg per kg plus intravenous immunoglobulin plus aspirin.
Thank you.
You say that you had only 4 cases of ectasia of the coronary, and all of them recovered within
Everyone
3 months.
recovered. Everyone
all 4.
yes.
But when you have also gone through the studies of others, you mean to say like other studies also showed such a 100% resolution of
There was only
ectasia?
2 studies which did not show 100%, ma'am. The all other 6 studies have shown 100% clear resolution of the coronary ectasia. One study, Kapoor et al., had 10% of the children with persistent coronary ectasia even after 6 months. Almost all the studies have shown resolution of ectasia.
Okay. And you said only the ESR alone, standalone, was very significant, where I'm sure when you have referred, it would have been ESR and CRP plus ferritin, and also interleukin 6 was done in many. I don't know, the resource limited settings you can't. So what is your take on that, why your patient CRP did not match the others?
The patients had a very high CRP. Patients had 140, 100 CRP. But statistically, it was not matching. Like every children had elevated CRP, we could not statistically correlate. But the other way, every children with cardiac manifestation had ESR above 70, most probably. So probably statistically here, I could relate only ESR to cardiac manifestation, not CRP to cardiac manifestations.
Well done, very good presentation. And one thing is, slides are good, but don't put animation. Brief questions, I want brief answers. How often you check the cardiac enzymes and how often the echo was done?
Cardiac enzymes was done initially and after 7 days. Echocardiography for ectasia child once every week until discharge, then monthly for the next 3 months, then once every 3 months for next 1 year.
And the fall ESR, when did it get normalized?
ESR got normalized by day 9 or day 10.
Okay. And do you think that you should follow these children? I know they follow period was 3 months. Do you think you need to see them again after 1 year or something like that to see what happened?
We followed the children until 1 year actually.
Thank you.
Thank you, Dr. Karthipan, and thank you, judges. The next presenter is Dr. Aishwarya Abirami to compare the efficacy of HFNC and standard oxygen therapy in moderate bronchiolitis.
Good morning, everyone. My presentation is on outcome of high flow nasal oxygen therapy in bronchiolitis. The objective of this study was to evaluate the outcome of high flow nasal oxygen therapy in bronchiolitis in the pediatric intensive care unit and children ward in a tertiary care hospital. Acute bronchiolitis is an important cause of morbidity in infants. It is the most common cause of hospitalization due to acute lower respiratory tract infection in infants aged less than 2 years. According to WHO, an estimated 150 million cases occur annually. 11 to 20 million of these cases are severe enough to require hospital admission. Though recent studies have proven significantly lower treatment failure by HFNC, there is no data on the efficacy of HFNC in reducing the need for mechanical ventilation, ICU care, and duration of hospital stay. And this study was hence conducted. In Study Center, Pediatric Intensive Care Unit and Children Ward, the study period was March 2020 to March 2021, and the study design was open labeled randomized control study. The inclusion criteria for the patients were infants fulfilling the case definition of moderate bronchiolitis by the bronchiolitis severity score and age of more than 2 months and less than 2 years. Exclusion criteria was acute bronchiolitis with respiratory failure, infants with other diagnoses like recurrent respiratory tract infection, bronchopneumonia, B's associated lower respiratory tract infection, and congenital heart disease, and chest wall deformities, congenital malformations such as cleft lip, palate, and retrognathia, laryngomalacia were also excluded, and infants presenting with circulatory shock and infants of severe acute malnutrition were also excluded from the study. The methodology was enroll 150 children with bronchiolitis were first randomized to 75 in each group of intervention. Group A was given HFNC therapy and Group B given standard oxygen therapy. The basic data regarding the presenting complaints and clinical status based on the pediatric assessment triangle were recorded on admission, and the clinical parameters such as respiratory rate, heart rate, work of breathing, cyanosis, oxygen saturation were recorded in response to intervention at regular time intervals, that is second hourly. And escalation, that is requiring mechanical ventilation, and de-escalation of oxygen therapy were measured. The sample size was calculated from the study by Philip Duran based on his outputs of expected mean and standard deviation of the duration of oxygen therapy. The other parameters considered for sample size were 80% power of study and 5% two-sided alpha error. The primary outcome of the study was to compare the outcome of children with bronchiolitis treated with HFNC and other modes of oxygen therapy, while the secondary outcome included reducing the duration of oxygen therapy, reducing the need for mechanical ventilation, reduction of duration of stay in hospital, and the possible side effects of HFNC. Coming to results and findings, this was the short form of the study. First, the children were assessed for eligibility, that is around 180, and around 20 were excluded based on the exclusion criteria, and 10 of them declined to participate, and coming to a total of 150. They were divided into two groups, Group A with 75 and Group B with 75. Group A were given HFNC therapy, and of which 72 improved and 3 required escalation of care. From Group B, that is who were given standard oxygen therapy, 60 improved and 15 did not improve. These are the results. That is, the mean duration of oxygen therapy was 1 day in Group A compared to 3 days in Group B, and the p-value less than 0.001. And the mean duration of stay in pediatric ICU was 1 day in Group A compared to 3 days in Group B, and Uh, Based on the requirement to mechanical ventilation, in group A only 4% required escalation to mechanical ventilation, whereas in group B 20% required escalation. Based on duration of hospital stay, it was 4 days in group A treated with HFNC compared to 7 days in group B treated with other modes of oxygen therapy. So the conclusion of this study was high flow nasal cannula therapy has shown significantly better outcome in bronchiolitis compared to other standard modes of oxygen therapy. Thus, HFNC can be the mainstay of therapy in children with bronchiolitis having severe respiratory distress, preventing the need for endotracheal intubation when initiated earlier. HFNC significantly reduces the duration of oxygen therapy and duration of stay in hospital in infants and bronchiolitis compared to standard oxygen therapy. HFNC, when used cautiously, will have significant minimal side effects, that is air syndrome, compared to endotracheal intubation. But however, the non-responders to HFNC should be identified and treatment should be stepped up as early as possible. Thank you.
Good presentation, finished well on time. I just want to ask you, that you told that 15 did not improve on standard oxygen therapy. What did you do without 15? Standard oxygen therapy, in that chart, 15 did not improve. So what did you do?
They were given HFNC, sir.
So when was it? Was it after a certain number of days, or what are the parameters? Because I just want to know, is it certain duration you waited before you escalated the treatment, or what exactly were the parameters you used to do that?
So change of decision was made within the first 2 hours. The parameters recorded were basic heart rate, respiratory rate, and requirement of FiO2. Within 2 hours, if I did not find any improvement in heart rate, that is either heart rate getting into the normal limit or either reduction by 20% and respiratory rate reduction by 20% or getting within the normal limit, we hike the treatment, sir.
The reason I'm asking this question is because you know that the duration of hospital stay was 7 days in standard group oxygen therapy,
Yes,
compared to the other one. So I just want to know the clarification. That's the reason I'm asking this question.
It was the total stay of the child, sir. So, but we did not wait to escalate the treatment.
It's a good study. Okay, but you have done it in the peak COVID period. If I look at it right, 2020 March, April, right?
Yes.
So because it was at the peak COVID, presenting with respiratory distress, was there any COVID positivity in these babies?
No, ma'am. We did not include those children.
No. What I'm asking is, you would have done, right? Or you didn't do? Because sometimes, because that was the time we were doing for that. Did you exclude anybody because of COVID positivity or something?
We actually excluded, ma'am.
Yeah, but you didn't put it in that. You said only known Valerie and all that you have excluded. And for those 3 who failed HFNC, did they require ventilation?
Yes, ma'am.
They were put on
Yes, ma'am.
mechanical ventilation, and what was the outcome?
They survived.
Yeah, so there was no mortality in this.
No.
Okay.
Couple of questions.
Yes, sir.
Can you just go to your conclusion?
Yes.
Okay, it's not being projected. Okay. So how did you conclude the HMC when used cautiously will have minimal side effects? There was no data supporting that conclusion. Was there one? Because there are not very many complications as such. So we could say that we didn't see any complications with HMC, but to say when compared to endotracheal intubation, we probably may not be able to conclude. And the second question is, what is regarding the ethics of not providing respiratory support and just giving only oxygen? Did you get an ethical clearance for this study?
Yes, sir. We did.
So it was approved in your ethical board?
Yes, sir. But it was only for moderate bronchiolitis.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Aishwarya Birami, and thank you, judges. That brings us to the end of the BRS award paper of Sangamam Pedicon 2.0. On behalf of the IAP Tamil Nadu State Chapter and the organizing team of Sangamam Pedicon, my heartfelt thanks to the judges for judging this most reputed paper of Pedicon 2023. On behalf of IAP Tamil Nadu, I request the office bearers to hand over certificates of honor to the esteemed judges of the day.
I've always told you that people experience it just for ours. Because what you do, it makes it good and bad. What we call for love, give meaning